Hello, it's Dr. James Hall. We're doing another video on kidney disease. Here's another question I get all the time. What are the most accurate and practical diagnostic tests for CKD, chronic kidney disease, in the primary care setting, and how do I interpret their results? So let's talk about it. First thing you want to order when you're in clinic is you want to order a BUN and creatinine. The BUN can go up with renal failure, obviously, but the BUN can also go up with dehydration and TPN. And the other thing that you probably don't know is blood loss. So let's review that. So the BUN, blood urea nitrogen level, can go up for dehydration. It can go up if you got plain old regular chronic kidney disease. It can go up if you have an acute kidney injury. It can go up if you're on TPN, total parenteral nutrition, and it can also go up if you have a GI bleed. The GI bleed makes the nitrogen level go up because lyse red blood cells in your stomach have nitrogen in it. And when those red blood cells lyse, that nitrogen is absorbed by your blood system, and you check that blood work and it says the nitrogen levels are high. Well, that's true, they are high, but it's not because the patient's kidney failure, it's because the patient has a GI bleed. So that's kind of a practical thing that you can use in your clinical practice, just knowing why a BUN would be high. The average provider, and I know you're not the average provider, would say high BUN, dehydration. High BUN, renal failure. But there's also other things, the TPN and the GI bleed. So don't just assume, try to be thorough. I know you're busy. I know you're seeing a lot of patients. You got a lot going on. Trust me, I know. I've been practicing nephrology for 20 years, and I know how it is. But I want to just try to help you guys understand and know how to effectively screen patients with CKD and what practical diagnostic tests to order and how to interpret them. We have a free webinar that has a lot of case reports that you can jump on that will help you make the leap from medical knowledge to clinical judgment. It's one thing to be able to sit and take a test, an A, B, C, D, or B, 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 C, 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 but to be able to take all that basic knowledge and go to a clinic or a hospital or intensive care unit and put it to work. That's where I come in. I'm going to teach you guys all the clinical things you need to know so when you're in clinic, you can quickly know what to do when you see these CKD patients. So, practical test, BUN, we talked about that one. Creatinine, you got to get a serum creatinine if you want to know if your patient has kidney disease. Creatinine is a breakdown product of normal metabolism, muscle metabolism. So, if your creatinine levels go up, it means that your body is not excreting them readily enough, fast enough. And there's a predictable excretion rate in our patients, and it's about 100 milliliters per minute. That's what we call the creatinine clearance. Is basically synonymous with your glomerular filtration rate. So how much creatinine you're clearing from your body in a 24-hour period tells us how good your kidneys are doing. If your creatinine clearance is 50, then your GFR is 50 milliliters per minute. If your creatinine clearance is 15 milliliters per minute, then that's what your GFR is. So we can do a 24-hour urine to tell us exactly what your creatinine clearance is. That's cumbersome. That's a lot of work. What we've done now is started to take a formula. There's several different formulas. One is called the MDRD. It takes into account the age, the race, the sex, the height, and all that, and the serum creatinine. And it will give you an estimated glomerular filtration rate. And so your lab should be reporting that. If your lab is not reporting the glomerular filtration rate with the creatinine and BUN, you need to request that. I mean, you guys are hiring these lab companies to do all this. You're making them money. requested the report of creatinine clearance, or GFR, estimated GFR, eGFR, that's what that means, on the lab. So you can quickly see what your patient's renal function is. That is so valuable to a primary provider, an NP, PA, physician, like a family doctor, internal medicine. That is so valuable to know, well, this patient's GFR is normal for their age, or this patient's GFR is low. Let me try to figure out why the GFR is dropping. That's so critical that you know that and have that quickly available, because you can see a high BUN, you can see a high creatinine, and the GFR may not be as bad as you think it is. For example, Shaquille O'Neal, who is 7 feet tall and weighs over 300 pounds, his serum creatinine is probably 2. And for a guy that big, his GFR is probably normal because he's so big. I mean, he's got more muscle mass, so he's got a higher serum creatinine than the average person. So that serum creatinine, when we check a renal panel on him, or CMP, is going to be higher than average. Most of the numbers we look at are averages for the average population. Always keep that in mind. There will be outliers. There's a bell curve like that. There will be outliers on both sides of the bell curve. And what are those outliers? Well, if you have extremes of weight or age, they don't fit the normal patterns of predicting the GFR based on what the lab says. For example, if there's an 80-year-old Caucasian lady with a creatinine of 2, her GFR is going to be a lot lower than a 45-year-old black man with the same creatinine. So you got to take into account, extremes of age and extremes of weight. What do we do in people like that? If I get an 88-year-old lady and I'm really trying to figure out what's her exact GFR, creatinine clearance, I would do a 24-hour urine for creatinine clearance on her. Now, if she was a 45-year-old Caucasian lady, I would accept the estimated GFR that's printed on the lab. It's accurate. But the older people get, the younger they are, then those estimated GFRs are not very accurate. Now, we get people 400 or 500 pounds in our clinic, nothing is accurate on their lab. Don't take everything with a grain of salt. So we got a big person over there. Remember that bell curve here now with labs and GFRs that's printed on there. I always do a 24-hour urine for creatinine clearance and for protein on that patient. There's another video earlier we talked about how to screen patients. We talked about a 400-pound guy who had obesity-related FSGS. We had to do a 24-hour urine on him to see what his real creatinine clearance is. The one reported on the lab is not accurate because he's so big. He's got too much fat and mass. Shaquille O'Neal, if he came to my clinic, I'd do a 24-hour urine on him to find out what his real creatinine clearance is. And you said 24-hour urine for creatinine clearance, 24-hour urine for protein quantitation. And that gives you a real-time sample of what they're excreting in 24 hours. It's no estimation, it's no formula, it's no calculation, it's real time. So that is the most accurate. But sometimes it's hard to do that. So if in the average population, most of your patients fit the average, and so you can be safe to use that estimated GFR that they print on the lab as their creatinine clearance. But keep in mind, as people age, their kidneys age too. So you have to know that a 40-year-old patient kidneys is not going to work the same as a 60-year-old. And so you may see chronic kidney disease in that 60-year-old with a creatinine that's normal. The creatinine could be 1, but the GFR could be 45. What does all that mean? That means that their kidneys are older, they don't work as good, but for that patient's age, their kidneys are working par for the course, normal for that age group. So keep this in mind. None of our kidneys are going to be working 100% when we get 80 years old. That would be great, but it's just not possible. But they still could be working good enough for what we have to do in our daily life. That's the key. As a provider, you have to really know that. So trends can help too, watching the trends in the creatinine and the GFR. So BUN, creatinine, GFR, we talk about those three diagnostic tests, practical diagnostic tests. The other one is urine. The urinalysis is really good because it can tell you if they have an infection, if they have hematuria or blood, if they have proteinuria, if they have bilirubinemia, which can indicate liver damage. The patient has bilirubin in the urine or some other type of issue. One thing about urine protein, the urinalysis tells you qualitatively, yes, there's protein, no, there's not protein. The urine protein creatinine ratio tells you how much. That's gold. That's what you need to know. That's clinically practical to what you're doing. 150 milligrams of protein in the urine is or less is normal. Greater than 250 milligrams is high. What do we do about that gray area, 150 to 250? I don't know. You try to get the blood pressure down, get the diabetes under control, do what you got to do. Or you recheck it in 3 months or 6 months. Kind of the gray area, proteinuria, I call it. So greater than 250 tells you as a provider, you got to do something. You cannot allow your patients to just have undiagnosed and untreated proteinuria. So if your patient has proteinuria and it's undiagnosed, you need to diagnose where this protein is coming from. Is it diabetes? Is it blood pressure? Is it obesity related, FSGS? Is it IgA nephropathy? Is it membranous nephropathy? Is it NSAID-induced nephropathy? I mean, there are millions of diagnoses out there. So as providers, we have to figure out what's causing this protein in the urine. And since there's not a lot of nephrologists in rural areas, and a lot of nephrologists are retiring, you're going to have to know how to manage these cases. So being able to quickly diagnose proteinuria, how much, and then start the workup process is going to be very helpful to you. The big thing, and if you see more than 3 grams of protein, more than 3,000 milligrams, that's an indication to biopsy. So you can write that on there. Severe proteinuria, we think the patient needs a kidney biopsy. That shows you're really paying attention to the details. Or if the patient has mild proteinuria, say if they got 275 milligrams, you can say mild proteinuria. Suspected early diabetic nephropathy. Suspected early hypertension, nephrosclerosis. That shows us that you're really thinking about why this patient has proteinuria. Proteinuria is the first sign of kidney disease. First sign of glomerular injury. The foot processes in your kidney help filter, and when they get effaced, when they start getting flat and start spreading apart, protein starts spilling through those foot processes and it gets to the urine. That's an indicator that glomerular injury is happening in a person's kidney. That's why we make such a big deal about proteinuria. So you look at proteinuria, you look at BUN, creatinine, GFR, urine albumin to protein ratio, urine albumin to creatinine ratio, the UACR. Albumin sometimes can spill in the urine before you see overt proteinuria. So that's why we check a urine albumin creatinine ratio. Same thing. If you see albumin spilling in the urine, more than 30, then you need to jump on that and try to figure out why. Most likely it's diabetes. But more than 300 is macroalbuminuria. It just means it's a lot. It means you need to aggressively get this patient on an insulin pump or whatever it is, put them on a pretty high-dose blood pressure medicine to get their pressure down if it's blood pressure, or figure out why. You can always do a renal ultrasound if you need to figure out if the patient has obstructive uropathy, kidney stones, kidney blockages, things that may be precipitating proteinuria. So this is the end of this video. Check us out in the next one. This video was basically talking about the most accurate and practical diagnostic tests in kidney disease in the primary care setting and how to interpret them. I hope it was helpful to you, and I hope it gave you some more insight on what to do in your clinic. And I want you to be able to bridge that gap between medical knowledge and clinical knowledge. That's our plan here. So check us out. Check our webinar out. We appreciate you. Goodbye.